So thank you very much. It's an honor and a great pleasure for me to be here. I'm very new to this. This is my first official contact with Radiating Hope. I started emailing with them end of last year, and they invited me to come here just to connect and see how we can work together. So I'm from a very different background, and I feel a bit odd here. I'm from Geneva, and better. And it's a very different world. We have a population in the Greater Geneva area, Switzerland, of about 1.2 million. We have 7 Linacs, we have at least 4 PETs, we have over 10 MRIs. So what you lack here, we have too much there. So it's really two opposite worlds. And it feels to me as an opportunity to use those facilities. We have, our machines are not full. We have the time to spend with the patients. We can spend an hour and a half for a new consultation. So it's a privilege, we can use it. And on the other hand, it feels to me as an obligation to reach out, to do something with our capabilities and to help. And that's why I'm here. So that's one thing. On the other hand, it also indicates that we're dealing with a very different population. Everybody, even 80-year-old women, are screened. So locally advanced breast cancer, the pictures that you saw so far, I've never seen them. So it's a bit of a challenging subject for me to talk about techniques while I'm not really very often confronted to these situations. I was talking to David Morgan yesterday evening, and I said, like, I think I've not even seen a cobalt. Thinking back about that, I think in my early training I've seen it, but as a medical oncologist, I've never really properly validated a plan in my own practice. So that's the context where you need to see this presentation in. So then we go ahead. What I want to talk about, do we need the mic? Can I be more? We'll go on with the mic? Okay. So what I would like to highlight is the volume definition, contouring, fractionation schedules, radiotherapy techniques, and then our own learning curve. I want to share with you what we learned from our first 20 to 30 patients that we treat for locally advanced breast cancer. Volume definitions. As already mentioned by Eleanor Walker, the most often site of recurrence is the chest wall. So if you treat, at least include the chest wall. Second frequent site is the periclavicular area. After a properly done axillary dissection, there's hardly any recurrences in that surgically treated area. And the internal mammary chain recurrences are there, but rarely reported. Then in absolute terms, a chest wall recurrence happens in 15 to 20% for the younger patients, 4 more positive lymph nodes or few uninvolved lymph nodes. Supraclavicular area recurrences are 10 to 12% for patients with 4 or more positive lymph nodes. And again, axillary recurrences are rather rare after a properly done axillary dissection. Higher risk for younger patients and fewer uninvolved lymph nodes. The more recent data show that the recurrence rate is only 2 to 3%. So really, if you do it, you can leave out the surgically treated area. So what are the practical guidelines that we use for, and here is a francophone issue, the CMI is the IMC, the chaîne mammaire interne, so it's the internal mammary chain. So I looked at it, like, oh, a French issue there. So for the N4+, we radiate local regional. So we take the chest wall or the breast, the periclavicular area, and the internal mammary chain. For the patients that are 1 to 3 nodes positive, we don't systematically treat all patients. We irradiate the chest wall or the breast when there's additional risk. Young age, grade 3, triple negative tumor. And the internal mammary chain, we irradiate it mostly dependent on the tumor's location. If there's an internal location, then we include that. As already mentioned, inflammatory breast cancer, you treat everything. Following neoadjuvant chemotherapy, and it's already been alluded, you really need to separate stage 2 and stage 3. If there's a stage 2 cancer, you can take into account a pathological response based on the chemotherapy. So if there's a complete response, you don't necessarily need to treat. If there's still positive nodes after neoadjuvant chemotherapy, then yes, you need to treat locally, local regionally. And again, avoid the surgically treated axilla. You don't gain in local recurrence or hardly, and you add significant morbidity. Stage 3, so as of T3 and N1 and all N2s and N3s and T4 tumors, irrespective of the response to neoadjuvant chemotherapy, you need to treat the local regional area. Contouring. There are several contouring guidelines. There's the ASTRO, there's the RTOG, that give very clear descriptions. And really, it's a good habit, good practice for the first patients that you start to delineate, to really take these contours, not contour the whole nodal area, but really separate it, level 1, level 2, level 3. It gives a lot of insights in where your limits are. This is the description, and it's not visible, not meant to be visible, but this is the description of the ASTRO guidelines. And it's really based on the vascular structures. The lymph nodes are mainly located around the venal structures, so that's what they base their descriptions on. It's not so much, it's going away from the bony structures, it's really looking into the vascular, so it's a good practice. The RTOG has a very elaborate description as well. It's just one thing I'd like to mention. Here you see in green, you have the internal memory chain. In blue, you have the supraclavicular, and it's a little gap. And that, I think, should be avoided. The structures need to be interconnected. So what happens here, you see it in more detail. In light blue, you see the supraclavicular area. We're going from the top to the bottom. Then you have a few slides where there's no delineation. And then on the lower image, you see the green coming up for the internal memory chain. The internal thoracic vein goes into the brachiocephalic vein, which is also already part of the infraclavicular area. So it should be in continuum of your structures in order to avoid an area of underdosage. One thing to be aware of, when you start delineating based on these guidelines, don't go over the borders of what we would treat normally based on the bony structures. So that is not necessary. And I've seen that a bit in the beginning of CT-based planning, where for the breast, for example, the CTV would be drawn close to midline, PTV up to midline, and then the fields for the tangent would go over midline. And it doesn't make sense to do more than we used to do, because in that area there are no recurrences found. And it makes a contralateral treatment more difficult. So be aware that you don't expand just based on these guidelines. And an illustration of that is from a Danish analysis. What they did for the period that you see, 2000 to 2013, they analyzed all the regional recurrences. They had about 100 recurrences, and it was divided in 3 groups. First image shows the patients that had, for their own preferences or comorbidities, no radiotherapy at all, while having positive nodes after mastectomy. So that's the left side. In the middle, you see the patient that received local regional radiotherapy, and on the right side, patient only having local treatment. And they analyzed where are the recurrences. And only in the middle group, they found one, and it's the lower one here. They found one recurrence that was outside the axillary field. It was an axillary recurrence. It was outside the field and also outside the breast tangents. That was outside the field. So their conclusion is, if there's a recurrence, it's in field. No need to expand the field size. The only question is then, should we increase the dose? And their conclusion is, based on the fact that overall, after radiotherapy, the number of recurrences, nodal recurrences, is relatively low. Don't increase the dose, because many patients not recurring will pay the price in terms of toxicity. Fractionation schedules. You already heard something about that. Here are the main trials for the not advanced breast cancer. You see the years, don't know if it's readable, but the number of patients, which are about 5,000 to 8,000, so several thousands. Standard fractionation was 50 gray in 5 weeks, compared to a hyperfractionation schedule. In the first 2 trials, done in 5 weeks, so 3 times a week, so the same length of treatment. In the last 2 trials, it was done 5 times a week, so in 3 weeks overall. And the conclusion is the local control is the same, and it might be better in terms of toxicity. However, on the lower line, it says that only few patients received local regional radiotherapy. So it is mainly about breast or chest wall. Based on these results, based on the fact that local control was similar, that if you do the recalculations, and it confirms an alpha beta of about 3 for breast cancer, if you do the calculations, then 15 times 2.66 is slightly less than 50 gray in terms of toxicity. 16 times the Canadian schedule is equivalent. Why not treat local regional in this? Many patients are being treated according to those schedules now. There's trials, big randomized phase 3 trials ongoing, so we'll get the answers. But in England, the consensus statement reads that there's no indication to use more than 15 or 16 fractions for local regional irradiation. The Dutch guidelines as well, no indication to do it, to use the normal fractionated schedules. So hyperfractionate everything. Good thing is that the trials are ongoing, comparing normal to hyperfractionation schedules for the local regional areas, because in Switzerland we have a big issue moving into the hyperfractionated schedules. And the reason is simple, we're paid per fraction. So using 5 weeks, moving from 5 weeks to 3 weeks makes us lose a third of our income. However, the states, the countries around us where we're paid overall per treatment have no problem moving to hyperfractionated schedules. Radiotherapy techniques, and as indicated, I'm a bit challenged here. I'll present to you what we've done, and hopefully it may be of some use for you either now or in the future. 2 techniques that earlier in my training we started with the table rotation, and when I was a medical oncologist, a radiation oncologist, myself, we started using monoisocentric treatments with light tangents to include internal memory change, so you go over midline and you add the supraclavicular area to that, so monoisocentric half-field techniques with field in field, so with segments in those treatments for both the breast and the supraclavicular area, so multi-segment monoisocentric techniques. And we compared this for several patients to a VMAT technique, so an ARC technique. And on the left you see the ARC technique, on the right you see the monoisocentric multi-segment technique. And what you see is that the conformality is better, especially for the supraclavicular area, for the VMAT technique compared to the monoisocentric technique. And here you have a better comparison. IMRT or ARC, we had never really used IMRT, but we use VMAT. Compared to the 3D conformal treatment, you see that the higher dose range, there's an improvement for the VMAT. There's a real gain. However, the low dose bath, you lose with the VMAT. There's a much wider spread of the low dose in terms of the volume. And if you compare those techniques, then you have a better PTV coverage, you have a better homogeneity and conformity with the VMAT. You gain in the high dose for the lung and heart. However, with the monoisocentric multi-segment technique, you gain overall in the lower dose. You have an ipsilateral lung with a lower V5, contralateral lung, contralateral breast. You really have lower doses. You can spare them almost completely. Then, something that I think is important, and I just want to highlight, is the breath hold techniques. We started using them for the left-sided breast, and now we do them for all local regional breasts, left and right. There is a significant reduction of dose to the heart, to the LAD, to the lung and liver for left-sided breast, and also for lung and liver for the right-sided breast. So you reduce the heart dose, and you reduce lung dose. So there are several techniques. I just want to quickly highlight them. Varian, the RPM, a little box placed lower on the thoracic wall that is followed by a camera and gives the breathing cycle with the patient being asked to take a deep breath. You define the threshold where the patient is being treated in, and that can be coupled to the machine. There's the dinner system of SDX, which is a spirometer. Patient is breathing with through the spirometer that's measuring the lung volume, The nose is blocked and they have goggles and they see their own respiration, they see the breathing target, and they can get themselves into the threshold and block their breathing. And then the Electra ABC, which is more or less a similar system, but actively uses a valve for blocking the breathing. Then I want to close with our own learning curve. What did we do when we started in the center where I work now? We started defining our techniques for locally advanced breast cancer. Am I blocked? There we go. So we position for early breast cancer, we position everybody on the breastboard. For the locally advanced breast cancer to be able to pass with the arc of the machine, we position patients on the stereotactic table with the overhead arm positioner. And here you see the positioning that we use. The head is turned to the contralateral side to have access to the supraclavicular area. We use the external contour is expanded by 5 millimeters to create the skin flash. Otherwise, the leaves will move totally to the skin, and if the breast will expand, then you underdose the superficial area of your PTV. We started with 4 arcs, we really needed them, but now we're comfortable and managed with 3 arcs for about 230 degrees. The optimization is done not on the PTV overall, but on the different parts of the PTV. Otherwise, one issue that you have in one PTV can be compensated by the other PTV, so we really need to optimize on the separate PTV structures. And you need to be careful where to place your IC center so that your arc can fully go around the patient and to avoid collision. These are the dose constraints that we use. For the ipsilateral lung, in general, V20 is aimed to be around 50 to 20%. A mean dose around 10%. Contralateral lung, really as low as possible. Overall lung, not go over 10 gray overall for the mean dose. A V5, below 30 to 40%. And this was really part of our learning curve, which I show you that initially the V5 was very high in the ipsilateral lung, and then we managed to get it down. Heart, even including the intermammary chain, mean dose 3 to 4 gray. Spinal cord, lower than 15 gray. We use that because if the patient comes back with metastases in the cervical vertebrae, then it's no problem to give 10 times 3 gray without having problems for the spinal cord. Contralateral breast, below 3 to 5 gray. Thyroid, try to spare one side. Esophagus as low as possible, and the humeral head not go over 25 to 30 gray. Something of our learning curve. Here you see the 95% coverage of the PTV of the breast or thoracic wall going up from 80% to 100%. So there's a really real curve that we saw progress in the first 20 patients. Supraclavicular area is more easy to cover, so there's more or less a straight line. The mean heart dose going from 12, 8 to now steadily 3 to 4 gray. We have a peak at patient 18. Looking back at the data, that was a patient that had a positive mediastinal node. So there the volume was much bigger. So that is helpful. If you have these graphs for your own experience, you can see what you aim at, you can see what you can target, and then when you have an exception, you can go back and see why is this an exception, and you can start to explain that. The V5 for the lungs, starting from 70 to 80% going, no, do I say that correctly? Yes, 70 to 80% for the 5% of V5 for the lungs, going now down to 30-40%. Mean lung dose starting at 12%, now being around 6 to 8%, 12 gray, now going down to 6 to 8 gray. And then homogeneity, going up. If it's 1, it's perfect, going up over time. So with this, I want to conclude that if you start introducing new techniques, it's really important to start a database of your own patient treated. Record all the relevant dose levels for PTV and organs at risk so that you can observe your own learning curve. Make comparisons for the new plans based on the previous ones. It will give you a gain in time. I remember when we started with the VMAT, The dosimetrist would come in 3-4 times a day asking, Connie, can you look at this? I tweaked it a bit, can you look at it now? And now when I see the plans, they know what to aim for, they know the objectives, and they'll come in at the end and either it's perfect or I need to tweak it a little bit and we can move on. So it really gains time and your plans will be more homogeneous. So that was what I wanted to share with you for the techniques of locally advanced breast cancer with greetings from Geneva. Thank you.